We can start.
So we are live, you can begin.
Okay, so good evening, everybody. We welcome you all at the Muscat International Ophthalmology Conference of 2021. We are in the Uveitis Session today, and we have a number of distinguished guests. We will start the session by a principal speech by Prof. Kwan Nguyen, who is currently the General Secretary of the International Intraocular Inflammation Society. He is a professor of ophthalmology at Bayer's Eye Institute at Stanford, and he has completed his medical degree at the University of Pennsylvania and finished the residency and fellowship at Massachusetts Eye and Ear Infirmary at Harvard and Wilmer Eye Hospital at Johns Hopkins. He's a prestigious scientist and clinician in the field of intraocular inflammation and uveitis. And we are very happy to have him on board here tonight. So Prof. Kwan, you can start your lecture. Thank you.
Thank you, Majid, and good evening, good afternoon, good morning, everyone throughout the world. Majid, can you see my slide?
Yes, I do.
And now it should be in the full screen presentation. Is that correct?
Yes, yeah, we can use it. We can see it.
Certainly, it is my great honor to be able to join everyone, colleague here. Thank you, Dr. Majid, and the organizer for asking me to join you at this year, the Muscat International Ophthalmology Conference. I've been asked to share with everyone some of the work that currently ongoing for the development of novel treatment for non-infectious uveitis, and definitely would like to discuss that with everyone. As a way of disclosure, our university received research funding from various organizations and pharmaceutical groups. In addition, I chair the steering committee for a number of studies in uveitis. During the past decade, a number of different pharmacologic agents has been investigated for our field ocular inflammatory disease and uveitis. Some of them I have listed here, such as those for interleukin-6 inhibition, tumor necrosis factor inhibition, Janus kinase 1 inhibition. Today, I would like to share with you some of the ones that are currently ongoing, including the corticotropin melanocortin group, as well as some upcoming ones, the vectorized molecule, the interleukin-17 inhibition, and finally, we will finish with the currently ongoing phase 3 study for mTOR inhibition. So let's just begin some of this description here. First, this is focused on ACTH corticotropin for uveitis and ocular inflammatory diseases. ACTH is part of the melanocortin pathway and endogenously produced. The product is a result of a cleavage of precursors. There are 5 different types of melanocortin receptors, and each one has a different affinity for each. ACTH can bind with all 5 receptors. Where do we have corticotropin? This product actually has been approved by the FDA since 1952. The reason for less commonly used in ophthalmology is because of the lack of data, no clinical trial, and in addition, steroids was introduced. Corticotropin was thought to act only via the steroidogenic pathway, which has now proven to be incorrect because there are numbers of the pathway that has been established. Currently, corticotropin has been used in various indications such as nephrotic syndrome, multiple sclerosis, dermatomyositis, among others. In 2016, we published for the first time the use of subcutaneous repository corticotropin for non-infectious panuveitis. Was a case that we discussed in which we use it successfully in patients with retinovasculitis. Since then, we have launched a study named the ACTA study, which is ACTH as re-emerging therapy for uveitis. This is a phase 2 multi-center study across a number of centers in the United States. evaluate the potential role of corticotropin in the management of non-infectious posterior and panuveitis. In this study, subjects are randomized 1-to-1. After they've been randomized, would be treated for 2 weeks, 14 days with daily use of melanocortin corticotropin. Subsequently, they then randomized to be used every twice weekly or 3 times weekly. And then the treatment ongoing until month 6, which was the primary endpoint, and subsequently it been used as needed until month 12. So this study is currently actively enrolling in the United States, and hopefully it will be in the future provide us additional information. In addition, I'd like to share with you a case of another indication. So this is a patient of mine, a 30 years old Caucasian man with bilateral idiopathic diffuse anterior vasculitis for 2 years or so. The patient has been unresponsive to indomethacin, adalimumab, and methotrexate. The symptom improved with very high dose prednisone, 1 milligram per kilogram, but the patient suffered significantly from side effects, including significant weight gain. This is the presentation of the patient on May 24, 2017. And at that time, the medications were prednisone 30 milligram a day, along with azathioprine 150 milligram q-day. At that time, the patient had moderate discomfort with a mildly elevated blood pressure of 145/90. So at that time, we decided that we should stop azathioprine. Given the fact that patient have diabetes, we also taper prednisone to off relatively quickly. And at that time, we started the patient on ACTH gel at the dose of 80 units 3 times a week. 3 months after that, we noticed a complete quiescence of the sclera with very much no inflammation at that point. We're quite pleased with that. And so based on just findings, how successful it can also be used in ocular inflammatory diseases such as scleritis, we have launched a phase 2 multicenter study that evaluates the role of corticotropin also on scleritis. And this study is also currently enrolling in the United States at this moment. Well, so we hope that in the future, the use of corticotropin can be made available with much more data to support its use in uveitis and ocular inflammatory diseases. Other studies are ongoing using this aspect as well, including that for acute demyelinating optic neuritis led by Dr. Robert Surgott at Wills Eye Hospital. Dr. Foster has been using it for retinal vasculitis, and then Dr. Peter Campaccio at the Wilmer Eye Institute has been using it for proliferative vitreal retinopathy as well. So we have a number of indications pending its potential usage. Let us now briefly discuss a second group that currently in a study, and this is KT-8261, which is an intraocular vectorized molecule, which is a form of vector gene therapy, which are designed to develop and manufacture to improve the speed to the market and deliver to the reduction in the cost. As we know, vector therapy or gene therapy are extremely expensive, and that can prohibit the use in a number of indications. So we hope that this would be able to provide that usage. We hope to advance novel and gene therapy to address a range of ocular diseases, including uveitis. KT-8261 is currently in preclinical stage development as a focal intraocular injection of a vectorized molecule. The potential benefit of expression of a vectorized molecule within the eye include the fact that it can reduce toxicity, actively higher local concentration, and one and done, it continued protection against autoimmune or inflammatory insult. So the idea is that we will be able to provide one treatment that can provide, for example, a product X that will be able to last continuously to control the inflammation. And the trial are currently being planned right now for this molecule there. The third aspect we're going to look at today is the question of interleukin-17 inhibition, and we will be discussing the potential role of izokibep, which is ABY035. The question we have here is interleukin-17 a proper target for ocular inflammation? And with that, let us look at the literature. In the literature, we have seen that interleukin-17 level are elevated in the serum and aqueous humor of the heterogeneous population of patients with non-infectious uveitis. In 2013, the result of secukinumab, which is an interleukin-17, was published to look at its potential role in the treatment of non-infectious uveitis. And this is the result of several randomized clinical control trials. In this study, secukinumab was associated with a reduction in the mean total post-baseline reduction to show its potential role. However, the primary efficacy endpoint of the 3 studies were not met when secukinumab was given as a subcutaneous injection. Subsequently, a few years later, the team from Boston and others have shown, however, when secukinumab, an IL-17 inhibitor, was given as an intravenous delivery, at that time, significant success were noticed. So therefore, the role of interleukin-17 and inter-17A inhibition for non-infectious uveitis remain to be confirmed. Is it the mode of action or is it the mode of delivery that is being tested correctly? There are several rationale for developing a novel 17 inhibitor for non-infectious non-anterior uveitis, and that is this target therapy can be quite helpful and can yield better efficacy and safety. Instead of giving a very non-specific corticosteroid, if we can focus on a particular interleukin or pathway, that would be very important. In addition, Th17 cells are a very key player in the pathogenesis of the disease. And in a number of patients, such as those with the check disease or the level of IL-17s are quite elevated. In clinical trial, there's been promising sign of efficacy after intravenous dosing, making interleukin-17 inhibition in uveitis a very valid target. And in addition, we also have a safety and efficacy of interleukin-17 inhibition proven in different diseases. Azokibep, or ABY035, is a biologic that acts selectively and potently as an interleukin-17 inhibitor designed to be quite strong in this class. It binds to 2 domains of the interleukin-17, is trapped completely the molecule IL-17 homodimer in that. And because of that, it has exceptional affinity and selectivity for IL-17. In addition, its small size make it also quite easily used. ABY035 azokibep has a unique property in that it binds IL-17 with high affinity. It also has an extended circulatory half-life, therefore it can stay in the substance quite longer. Thus far, as I have alluded to, it is quite well tolerated and accepted with the safety profile. We do have data from the first in-human trial of ABY035 in healthy volunteer and patient with psoriasis. In addition, patient with moderate to severe psoriasis is also show efficacy in terms of other indication as well at different doses. As I've alluded to, it appears that high doses of interleukin-17 inhibitor are needed in uveitis. And so far, with this antibody platform, it seems to be possible. As we just showed it to you, when IL-17 in the form of secukinumab was given as subcutaneous, it did not seem to be efficacious. On the other hand, when it's used as a intravenous doses in the several phase 2 study, it appeared to be quite efficacious. So therefore, how are we going to address this? Well, the technology that with the current platform with azokibep, it appears that platform can deliver quite an efficacious dose in a convenient 1 ml subcutaneous volume that can be equivalent to a very high dose of the intravenous secukinumab. So therefore, given the success of the secukinumab at the high dose of the intravenous, we expect hopefully that this azokibep can also provide with such treatment for that aspect. The linear study designed to test azokibep, and it is a phase 2 trial to look at the role of an interleukin-17A inhibitor and ABY035 in the treatment and prevention of relapse and recurrence of non-infectious intermediate posterior or pan-uveitis. The trial designed to be multinational, multi-center, and phase 2 proof of concept here aspect in uveitis with significant baseline disease activity despite treatment with a high dose of corticosteroids. In this case, 7 to 40 milligram daily. There are various key inclusion criteria for this program. First, it has to be diagnosed with either unilateral or bilateral active non-infectious uveitis. Second, the activity disease at baseline can be defined by several criteria. It does not have to have all of them, but it has to have at least one of them. And that is, it can have an active inflammatory chorioretinal or inflammatory retinal vascular lesion, or it can also have vitreous haze. So as we know in our field, not every type of uveitis would demonstrate all findings. In other words, some certain type of uveitis will have more haze, while other demonstrate by their activity to various lesions, and thus we are able to enroll in both types. In addition, the patient should have been on the treatment with oral corticosteroid from 7 to 40 milligram a day prior to admission, so that it would be able to be stable prior to the patient being enrolled in the study. And currently, the linear study is designed to have two parts. Part A, to evaluate the efficacy of this drug in treating active uveitis, and then part B, to investigate its role in preventing relapse and recurrences, this aspect. In addition to the primary endpoint, I mentioned there's a several secondary objective, including the safety and the exposure of the drug in the plasma. And currently, the linear study is being launched in Europe and North America. And our group at the Bio Institute at Stanford are currently screening various subjects to be enrolled in this study. So that's the third approach that I just mentioned to you. And now we're going to finish with the last point I want the late study in this, and this is looking at sirolimus for patients with non-infectious uveitis. Intravitreal sirolimus is a novel immunoregulatory agent that can be locally delivered. This is a mode of action to the blocker of mammalian target of rapamycin or mTOR. This can immunoregulate by interrupting the inflammatory cascade and promoting immune tolerance. Sirolimus inhibits T cell activation, proliferation, and differentiation. It also increased regulatory T lymphocyte. We have seen systemically deliver sirolimus to various types of diseases, including in its use in preventing organ transplant rejection. In the field of ocular inflammation and uveitis, we have also seen how intravenous sirolimus has been used systemically, but now we're looking at a proprietary intravitreal formulation where it can form a depot in the vitreous, and it can slowly diffuse over 2 months with minimal systemic exposure, as back from here. In 2013, we published the first study of looking at the tolerability and efficacy of intravitreal and at that time subconjunctival injection of sirolimus in patients with non-infectious uveitis. That's our first safe study. Subsequently, 2 years later, we showed the long-term outcome of that, showing that it can also help to maintain long-term stability. And that was either a subconj or intravitreal. Then at that time, we also look at how locally deliver of a immunomodulatory immunosuppressive agent can also improve the quality of life of the patient compared to systemic delivery of treatment, and that's also a positive finding. Because of that, we move forward to launch the phase 2 study of locally delivered sirolimus, in that case, using only intravitreal. And in this study, we randomize it either to 440 microgram or 880 microgram of sirolimus and intravitreally delivered. treatment was up to month 6 and with the subsequent follow-up at month 12. And with that, in 2016, we published the study to show that it can be quite efficacious. So based on the result of our phase 1 SAFE study and phase 2 safety study, we launched a program called Sakura program. That's the first program, which consists of 2 phase 3 studies, 1 pivotal and 1 supportive, randomized double-masked multinational study that have been conducted in the United States, Europe, India, Latin America, and Japan. And the object of this study was to evaluate the safety and efficacy of intravitreal injection of 440 microgram or 880 microgram sirolimus versus 44 micrograms. So 3 different doses will look at 44, 440, and 880 in active non-infectious uveitis. The study designs were as such. This was the largest study of non-infectious uveitis of the posterior segment to date. Sakura 1 had 347 subjects, and the subjects were randomized so that they can receive intravitreal sirolimus of 1 of 3 doses, 44, 440, or 880 at baseline, at month 2, and at month 4, with the primary endpoint at month 5. Subsequently, we learned that 440 microgram seemed to be the most effective dose to be used, and therefore, we in the Sakura 2 program, which has 245 subjects, we evaluated 44 microgram versus 440 microgram with that protocol to look at now just 2 specific doses and eliminating the 880 doses. So here's what we showed to you, the outcome of this. This is the outcome of the Sakura program, looking at vitreous haze response in study eyes at month 5. And we share with you the intent to treat population, which asks the question, what is the difference in the various different doses in reaching a vitreous haze of 0? So as you can see with this, 2 different color, 44 at the blue, the 440 is yellow, and the purple is 880 microgram. And with that, we see a statistically significant result between the 44 microgram and the 440 microgram, and no significant result in terms of the 880 microgram. This is looking for vitreous haze score of 0. If we look at vitreous haze score of 0 or 0.5 plus, because sometimes it's difficult to completely judge at to be 0. So if you look at vitreous haze of 0 or 0.5 plus, we also see the statistically significant difference between 44 microgram and 440 microgram aspect from there. So this is in the study eye. Now, the study have also looked at the fellow eye, because in the absence of an absolutely placebo arm, then the best way to compare is the fellow eye, which has uveitis, which did not receive treatment. And here we see the result of the fellow eyes. Again, the fellow eyes is now in gray, and we're looking at 2 different doses, 44 and 440. Again, we also see the statistically significant result between the 44 and the 440 microgram as well for vitreous haze of 0, as well when we look at vitreous haze of 0 or 0.5 plus aspect from there. So with that, we're confident that this is potentially can be a potential treatment with that aspect there that we have seen, because now we see that it can demonstrate positive results in eye that have not been treated and eye that have been treated, and we now reach it to a difficult endpoint, and we've been able to show the efficacy looking at vitreous haze in this aspect. So with that, we have shared our result to a number of publications here into intravitreal sirolimus for non-infectious uveitis. This is a Sakura program. Subsequently, we have published the overall review of this aspect to the various aspects to show. So that's the first program. And as we know, the FDA required that we have 2 successful programs in order to bring a drug to fruition. And with that, we currently have the Lumina study, which is the second phase 3 program that's currently being conducted in Asia, Europe, and North America. This is the second program, a phase 3 program, multi-center and sham control, to look at the efficacy and safety of intravitreal injection of 440 microgram sirolimus for the treatment of active non-infectious uveitis, the eye in here. So therefore, during the last 25 minutes or so, I have shared with you the development of 4 different approaches, looking at 4 different type of pharmacologic agent that may be helpful and available to us in the future as a form of treatment for non-infectious uveitis. And in looking at uveitis therapy, certainly it is very important to have we have a critical need for well-controlled, randomized prospective study that will help us to see it further. We know that we need for safe and effective agent, and so far we can see that specifically target therapy, such as those of IL-17 inhibitor, TNF inhibitor, or JAK inhibitor, that can be very helpful. Interleukin-6 inhibitor is also very powerful as well. We also see different mode of therapy, that is corticotropin. We also see novel delivery systems, such as intraocular vectorized molecule, and then with hopefully at the local deliver of an immunoregulatory agent, that is the form mTOR inhibitor. Certainly, no matter what pathway we look at, whatever molecule we look at, we know that the goal for any therapeutic approach is that we have no tolerance to any degree of inflammation, so that we can keep the eyes disease-free and inflammatory and inflammation-free in order to preserve vision. And with that, I thank you for your attention, and I look forward to our discussion. Thank you.
Okay, so thank you, Prof. Kwan, for the interesting and informative lecture, and it shows a very promising options of treatments in the future for the patients with uveitis. We're going to keep all the Q&A at the end, and now we're going to move to the second lecture by Dr. Shan. Dr. Shan is from Singapore. She is a medical retina and uveitis consultant at the Singapore National Eye Center. She had her residency training and fellowship locally at Singapore and also at Australia at Sydney Eye Hospital. She does have a wide clinical experience in the field of retina and uveitis, and we are very happy to have her on board here tonight with us. So, Dr. Shan, you can start your lecture.
Good afternoon, everyone. Thank you for joining us at the Uveitis Session today. My name is Shan, and I'm dialing in from Singapore, where I work as a consultant at the Singapore National Eye Center. Before we begin, I would like to thank the organizers of this meeting for this kind invitation. It is indeed an honor and privilege to be amongst the other distinguished speakers in this session, whom I have learned a lot from in other webinars like these and their publications. Today I'm going to go through a brief overview in the approach to a patient presenting with anterior uveitis. I have no financial disclosures. When a patient presents with ocular inflammation, I typically go through a checklist like this to help narrow my list of differentials and focus my investigations to avoid costly and unnecessary testing and guide the intensity and urgency of treatment. First and foremost is to determine the primary site of inflammation. For clinical and research purposes, uveitis is differentiated into anterior, intermediate, posterior, and panuveitis. According to the Sun classification, the primary site of inflammation in anterior uveitis is the anterior chamber between the cornea and iris. That said, it is not uncommon to have some spillover in the retrolental space when there is intense inflammation in the anterior segment. Whilst anterior uveitis accounts for about 50% of all uveitis cases, a patient should not be labeled as having anterior uveitis until a thorough dilated fundus examination has been done to rule out the presence of snowballs, retinal or choroidal infiltrates, and vasculitis suggestive of intermediate or posterior uveitis. I find this table of uveitic entities from Dr. Japp's seminal paper particularly useful and have encouraged all our residents to commit this to memory. As you can see, once the primary site of ocular inflammation has been determined, the list of diagnostic possibilities is narrowed. The differentials can be further thought of as being isolated to the eye or part of a systemic condition, or of an infective or inflammatory etiology. In anterior uveitis, laterality is particularly useful to help further differentiate the possible underlying etiology of the ocular inflammation. In a patient presenting with bilateral anterior uveitis, there is often an underlying systemic inflammatory condition such as sarcoidosis, Behçet's disease, juvenile idiopathic arthritis, or tubulointerstitial nephritis. Nonetheless, this may be asymmetrical or present with unilateral anterior uveitis initially. Conversely, apart from HLA-B27 related uveitis, which tends to be alternating, most unilateral anterior uveitis are of an infective etiology, and I almost always never label a patient with Posner-Schlossman or Fuchs heterochromic iridocyclitis until an underlying infective etiology has been definitively ruled out. In addition to anterior chamber cells and flare, it is also useful to ask and look for other signs and symptoms that help narrow the list of differentials further. In the anterior segment, this would include paying close attention to the cornea for any scars and keratic precipitates, checking the intraocular pressure, and looking for the presence of a hypopyon and any iris changes. It is important to standardize the grading of anterior chamber cells to assess response to treatment if patients receive shared care, and this is done using the parameters marked out by the Sun Working Group. In some places, a flare meter may be employed to grade flare more objectively. Another anterior segment sign that may be seen is the presence of a hypopyon. The most worrisome and sight-threatening condition associated with this is endophthalmitis, and this must be ruled out with a dilated fundus examination. A hypopyon in a white eye in an older patient should also prompt the exclusion of a masquerade syndrome. More commonly, a hypopyon in a patient with anterior uveitis is associated with fibrinous HLA-B27-related anterior uveitis and Behçet's disease. In Behçet's disease, this hypopyon is typically described as being mobile as it comprises neutrophils that slide readily over the cornea endothelium. Occasionally, viral anterior uveitis may also give rise to a hypopyon. If the hypopyon is stained or layered with blood, one should then ask about a history of trauma and look closely for any associated iris neovascularization or anterior segment xanthogranulomas. At times, there may also be involvement of the cornea in the form of epithelitis, nummular keratitis, stromal interstitial keratitis, endothelitis, or the formation of an immune ring. In such cases, one should consider the following infective etiologies or an underlying systemic immune-mediated condition, especially if the signs are bilateral and the history suggestive of on-systemic inquiry. Another useful clue in any patient presenting with ocular inflammation is the presence and even absence of keratic precipitates, or KPs for short. KPs are inflammatory cellular deposits found on the cornea endothelium, and one almost always never sees KPs in lens-related anterior uveitis. When present, KPs are typically found in Art's triangle due to convection currents within the anterior chamber. However, in patients with viral anterior uveitis or Fuchs heterochromic iridocyclitis, they may be seen centrally or scattered throughout the endothelium. In addition to their location, the morphology of KPs provide us a means to further characterizing the anterior uveitis. They may be broadly classified into granulomatous or non-granulomatous, which may include coin-shaped or nodular KPs seen in CMV-related anterior uveitis, dust-like KPs seen in HLA-B27-related anterior uveitis, and stellate KPs described in Fuchs heterochromic iridocyclitis. Granulomatous KPs are typically seen in viral infections and TB, as well as chronic inflammatory conditions such as sarcoidosis and BKH that has entered into a chronic phase. Iris changes such as the presence of nodules, the pattern of atrophy, and posterior synechiae have also been described with various uveitic diagnoses. Systemic diseases commonly associated with anterior uveitis include HLA-B27-related conditions, sarcoidosis, Behçet's disease, and GIA. Consequently, it is always useful to ask for systemic symptoms and look for systemic signs associated with these conditions. More than 50% of acute anterior uveitis patients are HLA-B27 positive. Of the patients that are HLA-B27 positive, 50% of them have systemic HLA-B27 related disease, and this is most commonly ankylosing spondylitis. Spondyloarthropathy refers to inflammation that occurs at the interface between ligaments and bones and typically gives rise to early morning stiffness as well as low back pain that is of a fairly insidious onset. Sometimes the systemic disease may be psoriasis or inflammatory bowel disease. So in addition to back pain and morning stiffness, one should also ask and examine for any associated rash and bowel symptoms. Sarcoidosis is a systemic granulomatous inflammatory condition that may affect any part of the body, but most commonly affects the eyes, lungs, and liver, so a systemic inquiry about respiratory and constitutional symptoms can be helpful here. Behçet's disease is a T-cell-mediated obliterative vasculitis characterized by specific diagnostic criteria including recurrent oral and genital ulceration and specific skin changes. 70% of Behçet's patients have ocular involvement, and whilst the most worrying manifestation is that of an occlusive vasculitis, some patients may present with only anterior uveitis at the outset. Anterior uveitis is the most serious complication in children with oligoarticular GIA and occurs in 20 to 25% of children with oligoarticular GIA. As children are not one to complain, it is imperative to probe further for any systemic joint pains or general malaise in a child with bilateral anterior uveitis. As mentioned earlier, bilaterality should prompt a search for a possible underlying systemic condition, and in particular any underlying syphilitic infection. As we are aware, ocular syphilis may present at any stage of a syphilitic infection, and there are myriad manifestations of ocular syphilis. Whilst it most commonly presents as a posterior uveitis, 20% of ocular syphilis cases may present with only anterior uveitis. Systemic signs are not commonly seen in tertiary syphilis, but chancres and a characteristic rash over the palms and soles may be seen in primary and secondary syphilis respectively. In addition to laterality, anterior segment and systemic signs, one should also consider the time course of the anterior uveitis to help narrow down the diagnostic possibilities. Acute uveitis is characterized by a sudden onset of symptoms and limited duration of disease. Uveitis is labeled recurrent when there are repeat episodes separated by periods of inactivity of more than 3 months duration, and chronic if there is a relapse within 3 months of discontinuing therapy. Earlier, we had this table to classify the specific uveitic entities based on laterality. Now, with an understanding of the time course of disease, we are able to break this table down further. Finally, looking for complications associated with ongoing ocular inflammation will guide the tempo of investigations and intensity of treatment and follow-up. Common complications associated with anterior uveitis include the following: cornea decompensation, raised intraocular pressure, the formation of cataracts and posterior synechiae, and the development of cystoid macular edema. Cornea decompensation occurs as a result of ocular inflammation, but is most significant in cases of CMV-related anterior uveitis, where uncontrolled inflammation may be marked by a rapidly declining endothelial cell count and cornea decompensation. Consequently, in patients with CMV-related anterior uveitis or where an underlying etiology has not been established, I find it helpful to monitor the endothelial cell count between visits looking for stability. Where HLA-B27-related anterior uveitis is commonly characterized by a low intraocular pressure related to ciliary body shutdown, other forms of anterior uveitis may give rise to intractably high intraocular pressure with ensuing glaucomatous optic neuropathy secondary to trabeculitis, or a secondary angle closure from the development of peripheral anterior synechiae or pupil block. Dense cataracts with posterior synechiae often develop sooner in patients with anterior uveitis than their age-matched counterparts, attributed to intraocular inflammation and the use of topical steroid medications. However, this should only be addressed surgically when ocular inflammation has been adequately controlled and disease is quiescent for 3 to 6 months. In addition to poorly controlled intraocular pressure, the other sight-threatening complication of anterior uveitis is cystoid macular edema. It is important to note that cystoid macular edema can be seen in all forms of uveitis, and one should not mislabel an anterior uveitis complicated by cystoid macular edema as a posterior uveitis. Cystoid macular edema develops in anterior uveitis as inflammatory mediators alter the permeability of the retinal vasculature, which leads to an accumulation of fluid within the retinal layers. It is believed that patients in whom there is a connection between the premacular bursa and Cloquet's canal are more prone to macular edema, as this serves as a direct conduit for inflammatory mediators to flow posteriorly. In the presence of cystoid macular edema, control of ocular inflammation should be particularly aggressive, as chronic cystoid macular edema is a common cause of visual loss in patients with uveitis. These are the systemic investigations that I consider in patients presenting with anterior uveitis. However, having worked through the clinical features discussed earlier, one should have arrived at a fairly concise list of differentials, and consequently the above investigation should only be ordered to help exclude important differentials or bolster the diagnosis according to the clinical features observed. In the presence of features suggestive of an underlying infective etiology or masquerade syndrome, I would also consider doing an anterior chamber tap for tetraplex testing and cytology respectively. To conclude, anterior uveitis is the most common form of uveitis. That said, before a patient is labeled with anterior uveitis, he or she must be dilated to exclude any posterior segment inflammation. Whilst the laterality and tempo of presentation is useful in helping us narrow the list of differentials, always perform a systemic inquiry to assess for any possible underlying systemic disease, and have a low threshold for an infective screen for syphilis and TB, especially if the disease is bilateral, chronic and recurrent, or if the patient is elderly. Finally, consider an anterior chamber tap if there is cornea scarring, characteristic KPs, iris changes, or high intraocular pressure to suggest an underlying infective etiology. Now, thank you very much for your time and attention, and I'm happy to take any questions in regard to this talk.
That was a great presentation by Dr. Shan. Now, let us move to the next speaker. Let us move to the posterior uveitis part. I'm very happy to welcome Dr. Soumya Basu. He is a head of uveitis services at LV Prasad Eye Hospital, Hyderabad. His main research is in immunogenesis in an ocular tuberculosis, as well as the role of autoimmunity in infectious uveitis. He has awarded ARVO Pfizer Collaborative Research Fellowship way back in 2013, followed by he has got a fellowship at University of Cambridge as well. He is a senior editor of Indian Journal of Ophthalmology since 2017. He is also a member of International Uveitis Study Group. He has almost 71 publications in peer-reviewed journals, as well as he has penned down 9 book chapters. So I'm very happy to welcome Dr. Basu. So stage is yours.
Thank you, Devdatta, and I hope I'm audible and my slide is visible.
Yeah, sure.
Yeah, wonderful. So thanks everyone, Dr. Majid, Dr. Samreen, everyone who's considered me for this talk. I think the first talk on anterior uveitis was covered very well, and I'm glad that my discussion on posterior and pan uveitis is pretty much going to follow the same pattern. No financial disclosures, of course, and just like mentioned in the anterior uveitis section, the primary focus, the first thing that you look for when you see a patient with suspected intraocular inflammation is the anatomical location of the disease. Where is the primary site of inflammation, anterior, intermediate, posterior, or is it a pan uveitis? And it might sound very obvious, but you see how easily you can reach at least half the diagnosis of uveitis without any kind of imaging or without any kind of laboratory investigation. Once you have decided that the primary focus of inflammation is posterior panuveitis, the other thing that you look for is the morphological classification of the lesions that you're looking at. So based on the depth of involvement, you would want to know whether it's superficial in the retina or retinal vasculitis, little deeper in the choroid, or is it still deeper in the sclera, or is it involving multiple layers? Then apart from the depth, you would want to know whether it's a posterior or a panuveitis. So as you understand, if the amount of inflammation, extent of inflammation is similar in the vitreous and anterior segment as well, then we call it as a panuveitis. And as we'll see later, many of the forms of panuveitis are actually extensions of posterior uveitis with significant vitreous or anterior segment inflammation. Now, once you have decided on the depth and the extent of inflammation, you next look at the associated ocular signs, and we'll come to it later, and the complications of the inflammation. And this could include retinal or choroidal neovascularization, epiretinal membranes or macular holes, or the retinal detachments of the tractional or the rhegmatogenous type. So these together form the entire diagnosis of posterior uveitis that you will make in your patient. The other part is actually borrowed from, again, what was also highlighted in the last presentation, the paper, the 2013 paper by Doug Jabs, which is absolutely fantastic. Anyone with the least interest in uveitis should, minimal amount of interest in uveitis should also be looking at that paper. Now, many times when we think of uveitis, we think of, trying to make a etiological diagnosis, and that is how we become a uveitis expert. No, that's not our goal in uveitis. Our goal before we start treatment is mainly twofold. The first goal is to rule out an infection, and this could vary depending on whether you're dealing with anterior segment inflammation or posterior segment inflammation. Now, in the anterior segment, if it's granulomatous inflammation, if there's a high intraocular pressure, there's a very strong suspicion of infection. Retinitis lesion, as we'll discuss very shortly, is infection unless proven otherwise. In fact, Behçet's and sarcoid are the only non-infectious causes of retinitis. Otherwise, it's always an infection. Choroiditis could go either ways, but if the choroiditis lesion also involves the retina, if there is significant vitritis, or the margins of the choroiditis are irregular, then think of infection as well. And then there are lab tests, and believe me, lab tests come much later. You can make a diagnosis of infection much before the lab test. So there are screening tests for syphilis and TB that can tell you an infection. So all these together rule out the first goal, which is infection. The other goal is to rule out a systemic disease, because this is going to tell you how you are going to treat the patient and not just the eye. And also how this disease is going to behave in the long run. How is it going to respond to treatment? For example, in weakage, we know that if we don't give the immunosuppression for a sufficiently long duration, then this is going to come back again and again. So the point is that do not focus on finding the cause of uveitis, but on finding factors that will decide the treatment and the course of disease. So, the two most common entities in the posterior segment are retinitis and choroiditis. And you see two very obvious cases here. The one on the left is a bright lesion with blurred margins, and you can see that some of the retinal vessels are disappearing into the lesion. Also, it's next to a pigmented scar, which really gives away the diagnosis. You don't need a blood test to make this diagnosis. This is a recurrent toxoplasma retinochoroiditis. Remember, I'm not calling it chorioretinitis, but retinochoroiditis. On the other hand, the picture on the right is one where you see the lesion is much deeper. It's not as bright as the lesion on the left, and the margins are better defined And most importantly, the vessels are all coursing over the lesion. So you know this is a choroidal lesion or a choroiditis lesion. So as I mentioned earlier, a retinitis, unless proven otherwise, is infection. So do everything possible to make sure what kind of infection you're dealing with, because that will decide your treatment. This is less of an anti-inflammatory treatment and more of a antimicrobial treatment that you have to do in most cases of retinitis. Now, these pictures here are of ocular toxoplasmosis. The one on the left is one where there's a retinitis lesion sitting next to a pigmented scar. So this is a recurrent toxoplasma retinochoroiditis, while the other hand, the one on the right doesn't have a pigmented scar with it. So this is a primary ocular toxoplasmosis. If you see very carefully, there's also a neurosensitive detachment around this retinitis lesion. So you don't make the diagnosis with a serology for toxoplasma, IgG or IgM, but this is an absolute clinical diagnosis that you make, at least for the picture on the left-hand side. For the primary lesion, you may have to do serological tests, or still better, you would want to do a Goldman-Whitmer test or a polymerase chain reaction to reach the diagnosis. Next comes this pattern of acute retinal necrosis. Remember, the acute retinal necrosis is a morphological diagnosis that could have several causes. The most common, as you're aware, is herpes simplex or herpes zoster virus. Now you see this whitening of the retina in the periphery with scalloped margins. You see the margins are all scalloped like this. Along with this, you can see involvement of the arterioles like you see here. So arteriolitis with retinal whitening, which could be multifocal in the beginning and then they become confluent, extending all over the peripheral fundus. That is a pattern you're looking for in acute retinal necrosis. Again, a clinical diagnosis. You don't have to do a blood test, for example, a IgG or IgM to reach the diagnosis. The other very commonly very similar condition that you would see is cytomegalovirus retinitis. Of course, you know, this comes in two patterns. The first pattern is, it's not exactly what you see here, but the first pattern is a more fulminant pattern, typically at the posterior pole, which has been called variously as a cheese or pizza pie or tomato ketchup, whatever. And the other one, which you can see in the same eye in the periphery and which is seen more commonly in non-HIV patients, is an indolent variety or a granular variety, which is seen more commonly in non-HIV patients or HIV patients with a relatively higher CD4 count. So this pattern is cytomegalovirus retinitis, again a clinical diagnosis. Now, the only form of retinitis that really needs a blood test to reach the diagnosis is ocular syphilis. And the test of choice is not VDRL or RPR, but the test is the treponema pallidum hemagglutination test, or the FTA-TPHA or the FTA-ABS test, which are the treponema specific serological tests, which will give you the diagnosis. So this is the only one that really needs a blood test. This can have several patterns. The one that you see very prominently here is called as superficial punctate retinitis lesions, which have small punctate lesions all around. Or you could have a placoid retinitis with a central clearing, which is another pattern. Most often these patients are immunocompromised, but they could also be immune competent. And remember, ocular syphilis is not at all a rare disease. It's becoming more and more common even in the immune competent patients. And again, when we talk of diseases that can present in any form, I think it is ocular syphilis that can really present in absolutely any form of intraocular inflammation. And it's good to screen for ocular syphilis, probably the only infection for which you should really screen for in all your patients. So moving on from retinitis to choroiditis, choroiditis lesions can be both infectious or non-infectious, but remember that it's very easy to confuse choroidal lesions from what appears like choroiditis but is not. And there are multiple patterns of choroiditis. I'll come to it in the next few slides. I think I'm running short of time, so I'll hurry up a little bit. So the thing with choroid is that it is hidden behind the curtain of the RP and the retina. So while in retinitis, the patterns are very obvious morphological patterns to reach a diagnosis, in choroiditis, they all appear similar. In fact, choroiditis also appears similar to the non-choroiditis lesions such as primary vitreoretinal lymphoma you see here with a leopard spot pattern, or a posterior scleritis that you see here, or the one below left, which is very commonly mistaken for choroiditis, is central serous chorioretinopathy with subretinal fibrin, or the one on lower right, which is a choroidal osteoma. So when you see a choroidal lesion, when you've ruled out a retinitis, you see a choroidal lesion, first thing is rule out a non-inflammatory condition or a non-choroiditis condition such as one of these. Now, once you're sure that you're dealing with choroiditis, you have to differentiate between infectious versus non-infectious choroiditis. Now, infectious choroiditis, while this is not a hard and fast rule, but infectious choroiditis is typically unilateral, though it may be bilateral. It doesn't have many foci. It is paucifocal, has irregular margins, and involves the retina and the vitreous. We'll see that in the next slide. So this is one form of infectious choroiditis. I think you're very familiar with this now, the serpiginous-like choroiditis pattern, very nicely seen on the fundus autofluorescence. The other thing is the involvement of the retina. You see that this is a choroiditis lesion, which is much bigger in size, and in the center of it, there is a retinal involvement. And if you run an OCT through this, you will see the involvement of the retina along with the choroiditis lesion. So these are all signs of an possible infectious etiology of the choroiditis. On the other hand, non-infectious etiology is typically it could be limited to the eye, or it could involve a systemic disease, unilateral, bilateral, but it's more often very regular, well-defined, and multifocal. Those are the signs that will tell you that this is more likely non-infectious. The APMPP and mutes are very well-recognized entities, also, called sometimes as white dot syndromes. We should try to come out of that kind of a classification, though. And, some of these, the white dots may not be very obvious. So the multimodal imaging may be very useful. In this case, a fluorescein angiography shows the wreath-like pattern in a case of mutes. This is non-infectious choroiditis with a systemic disease. You see the lupus pernio in this patient, or the potato-like mediastinal lymph nodes and the hypopigmented spots in the inferior periphery of a patient, all of which together are suggestive of sarcoidosis. The retinal vasculitis here is of a candle wax stripe. So all of these are signs of sarcoidosis, one of the causes of non-infectious choroiditis. Now, from choroiditis, we move on to retinal vasculitis. So retinal vasculitis is quite different from systemic vasculitis in the sense that we don't have a histopathological diagnosis of the vasculitis. We just call it vasculitis by looking at the perivascular infiltrates. And it is very frequently associated with infections and systemic disease. But, and this is very important, please note that it is very rarely associated with a systemic vasculitis. So conditions such as the granulomatous polyangiitis or polyarteritis nodosa, which are commonly causing systemic vasculitis, will very rarely be associated with retinal vasculitis. Now, when you see a retinal vasculitis, these are the points that you would want to know. What type of vessel is involved, size of the vessel, the morphology of the perivascular infiltrates, and the associated ocular and systemic signs. Now, the type of the vessel, more commonly we see venous involvement, and the conditions more commonly with venous involvement are TB, sarcoid, and Behçet's. Arteriolar, as I mentioned earlier, viral retinitis is the most common cause of arteriolar involvement. If the systemic vasculititis are also involving the retina, then also again it's arteriolar. Then again, you can have a mixed arteriolar venous pattern where it's again seen commonly in Behçet's disease. Now, the morphology could be just skip vasculitis, multiple foci of vasculitis, or it could be a confluent pattern. And there are other specific patterns which I'll come to very soon. Now, once you have looked at the type of vessel that is involved and the morphology of the vasculitis, you look at the associated clinical signs. And these really are the giveaway for the type of vasculitis. Now, the one that you see here is a retinitis lesion associated with a vasculitis, which is scarred here into a pigmented scar. In a TB endemic country, if you see these kind of lesions, please think of tuberculosis. I think this is one of the most important messages that I would like to give out in this presentation. Also, occlusive vasculitis or the presence of this tortuosity of the vessels within the area of vasculitis, these are also suggestive of a possible tubercular etiology. On the other hand, in sarcoid, you will have a candle wax, very florid perivascular, perivenular infiltrates, and with that, you will see these hypopigmented spots in the inferior periphery and association with granulomatous anterior and the peripheral anterior synechiae that you see here. All of these will tell you about sarcoid and you will investigate accordingly. Now, Behçet's, you know, it is associated with a fern-like pattern of leakage, diffuse capillary leakage that is seen in Behçet's disease. But remember, diffuse capillary leakage can be seen in almost any kind of posterior segment inflammation, including intermediate uveitis. The other is the mobile hypopyon, which was just alluded to. But remember that, I'm sorry, I have to stay here. But remember, as mentioned in the last presentation, Behçet's is diagnosed based on the clinical features, the ocular and the systemic features, and not by testing for HLA-B51, which could be negative in up to 40% of patients with Behçet's. Now, the other thing that you don't want to miss out is a retinitis lesion. For example, this peripheral retinitis lesion. If you have not looked carefully, you'll only see the perivascular infiltrates that are in the other quadrants and miss out on this retinitis lesion, which is a very giveaway diagnosis of ocular toxoplasmosis. No blood test required. Now, final point on panuveitis. This is a generalized inflammation involving all the segments of the eye. And this could just be an extension of the posterior uveitis, or it could be associated with exudative retinal detachment like VKH or sympathetic. Now, how do you diagnose VKH? This is based on the diagnosis presence of bilateral exudative retinal detachment, and this gives rise to a cobblestone pattern that you see here, or it could be more extensive into an exudative RD that you see here, or in some cases just present with disc edema, and the choroidal involvement will be more obvious by doing an indocyanine green angiography. Now, remember that many of these patients can just present with angle closure and can be misdiagnosed as angle closure glaucoma unless we take a very good look at the posterior segment. Now, this was the acute phase. If it is a chronic phase, then you have a depigmented fundus, which is called as a sunset glow. If it's not treated well, there'll be hyperplasia of the retinal pigment epithelium, which is seen like this, or with granulomatous anterior and hyperpigmentation of the iris. Now, the clue to diagnosis is on the OCT sometimes. If you are not able to make a clear clinical diagnosis, you see these multiple neurosensitive detachments that you see here, and it's these retinal pigment epithelial undulations which will help you distinguish the VKH from other forms of choroiditis. So summarizing again, please remember the anatomical classification, and once you have made this, go for the morphological classification into retinitis or retinal vasculitis versus choroiditis and posterior scleritis. The extent of involvement will differentiate between posterior and pan-uveitis, and the associated ocular signs and the systemic signs will give you the diagnosis. Don't miss out on the complications which are listed here. Ruling out infection and ruling out the systemic diagnosis remains paramount. Thank you very much for your attention.
That was a great talk, Dr. Basu, as usual. And you made it.
I'm sorry I exceeded the time. I tried my best to rush through it, but posterior uveitis is a little.
Yeah, I know. Yeah, that's what I said. You made it so simple. I mean, appeared so simple. So let us move to the next talk. Dr. Majid will introduce our next speaker. Dr. Majid. Okay. Our next speaker is Dr. Wataru. He will be talking on multimodal imaging in posterior segment inflammation. Welcome, Dr. Wataru.
Hello, everyone. Can you hear me?
Yeah, go ahead.
Okay, thank you. So I'm Wataru Matsumiya from Kobe University in Japan. Thank you for inviting me to participate in this conference today. I will present about multimodal imaging in posterior segment inflammation. Here is the multimodal images for the multiple evanescent white dot syndrome. Multiple white dot on fundus photography, early impacted hyperfluorescein on the fluorescein angiography, late hypofluorescent dot and spots on the indocyanine green angiography, mixed multiple hypo and hyperfluorescein spots on fundus autofluorescein, diffuse disruption of the ellipsoid zone on OCT, and decreased retinal response on the multifocal ERG were combined to evaluate and monitor the disease. This table showed pros and cons of each imaging modality. The advantages are following: closest appearance to a view via ophthalmoscopy in fundus photography, enable evaluation of the neovascularization, non-perfusion, and leakage in dye-based angiography, assessment of the RP function on the FAF, high-resolution cross-sectional image on the OCT, and visualization of vasculature without any invasion on the OCT angiography. I will show some representative cases which were evaluated with multimodal imaging. Forked Koyanagi-Harada disease, VKH, is a bilateral granulomatous uveitis with colloidal-based pathology. Here, fundus photo, OCT, FA, and ICZA are shown as imaging modality for VKH. This 46-year-old Japanese female developed VKH disease with exudative retinal detachment in the posterior pole of the each eye. OCT showed serous detachment with subretinal septa. In FA, multifocal leaks from level of the RPE demonstrate pooling into the subretinal space. ICGA showed multiple scattered dark spots after in the mid phase and staining in the late phase. Here's a representative OCT scan in the early stage of the VKH. Subretinal septa, green line in the serous retinal detachment, and RP undulation are specifically seen in the VKH. Subretinal septa are composed of the inflammatory products such as fibrin. This OCT scan of an eye with VKH also shows extensive choroidal thickening, which reflects a granulomatous infiltrate beneath the pigment epithelium as shown in the pathological section. Next, acute zonal occult outer retinopathy, AZOR, first described by Gass in 1993, is an idiopathic syndrome of the acute outer retinal impairment. Fundus photo, OCT, FA, FAF, OCTA, and multifocal ERG were utilized to evaluate AZOR. This 20-year-old Japanese female had visual field loss and photophobia in the left eye. Nasal visual field defect was shown in the Goldman test. Fundus photo looks almost normal. However, we can see the area of the subtle color change at temporal retina. Wide-angle OCT showed disruption of the ellipsoid zone corresponding to abnormal area in the fundus photo. Here, additional imaging were shown. The temporal retina with color change in the fundus photo showed hypofluorescein in FAF and low intensity area in unfast OCT at ellipsoid zone level. Multifocal ERG showed decreased response at nasal visual field corresponding to retinal region. On the other hand, normal vasculature was shown in FA and OCTA. This case met the criteria of the AZOR, acute visual field loss, decreased multifocal ERG responses, and outer retinal morphologic abnormalities. It is also reported that findings will change according to time course classification. In the next case, I will show disease mimicking azole complex. The disease were evaluated with fundus photo, OCT, FA, and ICGA. We can see the eye of the 37-year-old male with white yellowish oval region at posterior in the right eye and no remarkable in the left eye on the fundus photo. Vertical OCT scan in the right eye showed diffuse disruption of the ellipsoid zone and absence of the interdigitation zone on the abnormal region. Horizontal OCT scan also showed the abnormality of the photoreceptor reflection and hyperreflective dot in the colloid. Horizontal OCT scan in the left eye also showed a mild disruption of the ellipsoid zone around optic disc. These findings are compatible with azole complex. However, FA showed leakage from optic disc in both eyes and leakage from the retinal vasculature superior to optic disc in the right eye. Multiple scattered hypofluorescent spots on ICGA in the late phase were diffusely seen in the right eye and seen around the optic disc in the left eye. FAF showed hyperfluorescence of the region corresponding to abnormal area in angiography. These findings mean bilateral chorioretinitis along with vasculitis. Eventually, ocular gyphilis were defined based on the blood exam and the CSF test. Acute syphilitic posterior placoid chorioretinitis, ASPPC, is characterized by the development of the placoid macular deposit in the outer retina. ASPPC is a rare ocular manifestation of the syphilis. However, given the fact of the increasing prevalence of the syphilis, ocular syphilis is one of important differential diagnosis of the azole. Autoimmune retinopathy, AIR, is a rare disease with progressive retinal degeneration, which does not have a gold standard to monitor disease activity. Here, I will show image of the fundus photo OCT microperimetry and adaptive optics camera, which can depict each photoreceptor cell in this case. 56-year-old male who was diagnosed as AIR with positive anti-retinal antibody and anti-optic disc antibody had received intravenous immunoglobulin infusion and rituximab therapy. At that time, visual acuity in the left eye was 20/100 to 50. Fundus photography showed mild mottling in the superior macula in the right eye, and OCT showed diffuse outer retinal damage. 5 months later, visual acuity decreased to 20/500, although fundus photo and OCT showed almost no remarkable change. However, in the sensitivity map of the microperimetry, the area of the dark color, which showed a decreased sensitivity, newly presented around fovea compared to baseline. Here we can see AO image, microperimetry, and OCT at the same location. Left image shows the merged picture with AO and microperimetry using Photoshop. Middle picture shows AO image and horizontal OCT scan through the yellow box at baseline visit. In the yellow box in AO image, parameters were shown as below. Right picture showed those at visit number 2 5 months later. Visual acuity decreased from 20,150 to 2,500. Between two visits, AO image shows a change of the mosaic pattern and increased black spots. OCT also showed a hyper-reflective accumulation on RPE on the visit number 2. After analysis in comparison of the yellow boxes in the merged AO image between two visits, cone density in AO, retinal sensitivity, and outer retinal thickness decrease as parallel. Here are take-home clinical parts. Multidirectional images approach with different modality can improve disease diagnostic and therapeutic guidance. OCT findings such as septa and corridor thickening along with scattered pinpoint leakage on FA and multiple dark spots on ICGA will assist in making the diagnosis of the BKH. Infections such as syphilis must be ruled out before generating the diagnosis of the azole complex. Multimodal imaging is essential to diagnose and monitor AIR. AO may help to evaluate the progression of the disease. Thank you for your attention.
That was a great talk. Thank you, Dr. Wataru.
Thank you so much.
I now welcome Dr. Ayman. It's my honor to introduce Dr. Ayman Abdul Latif. She is consultant of uveitis and ocular immunology and associate professor of ophthalmology in the Alexandria University in Egypt. Dr. Ayman is interested in the different forms of ocular inflammation like uveitis, scleritis, and optic neuritis. She has many international publications and has been a guest speaker in international conferences around the world. Dr. Ayman, thank you very much for accepting our invitation.
Most welcome. My pleasure. How are you?
I'm good. Welcome. I hand over the mic to you now.
Okay. A very good evening to everybody. It's a pleasure to be part of the Muscat International Ophthalmology Conference. And for the coming few minutes, I shall share with you a simplified approach for the diagnosis of the white dot syndromes or causes of multifocal choroiditis, part of the curriculum we teach in Alexandria University in Egypt. I hope it is a method of breaking the ice between the ophthalmologist, whether or not he's interested in uveitis and this very big confusing problem known as the white dot syndromes. One the problem with white dot syndromes is that for the inexperienced eye, they might look all the same. You know, white or yellowish or orange patches. Some small, some large, some hypopigmented, some less hypopigmented, some irregular. And what is the way out of this confusion? Our algorithm or our approach depends on 6 clinical signs, 6 specifications. I shall share them with you in order, and then we will take one white dot syndrome, one of the causes of multifocal choroiditis, and apply the algorithm to it. The first point is the site and distribution of the lesions. By the way, the 6 points are clinical points because in my country and maybe in a number of developing countries, the extensive lab investigations are not very much feasible in every ophthalmology clinic, especially in the rural areas and the suburbs. So now to work, the first point is the site and distribution of the lesions. We describe the lesions according to the site and distribution into posterior, that is to say post-equatorial, behind the equator, or peripheral, that is to say pre-equatorial, in front of the equator. We further subdivide the posterior lesions into macular or peripapillary, that is to say around the optic disc. Lesions could be filling the fundus but sparing the macula, or sparing the peripapillary area. This is also a diagnostic point. And another part of the description that I consider very important is the quadrant in which you see the lesions. The second point is the size of the lesions, whether the lesions are small, medium-sized, or large. And here I take the opportunity to clarify a point that not necessarily the lesions start small and then enlarge. No. Some diseases, like for example, the PIC, the punctate inner choroidopathy, is characterized by small lesions all through the course of the disease. Other syndromes, like the birdshot chorioretinopathy, for example, is characterized by large lesions all through the course of the disease. So it is not a temporal sequence. It is not a rule that the lesions start small and then become medium-sized and then become large. It is a diagnosis defining feature of the disease rather than a sequence of events. The third point is the borders of the lesions. Are they well-defined or ill-defined? The fourth point is the color. Are the lesions hypopigmented or hyperpigmented? And to what extent are they hypopigmented? Are they chalky white or creamy or yellowish or orange colored? And if they are hyperpigmented, what is the pattern of the hyperpigmentation? This helps discriminate the different causes of white dot syndromes. The fifth point is the elevation. Are the lesions elevated above the retinal surface, which we call nodules, or not elevated? They are flush with the retinal surface, which we call patches. The sixth and the last and the most important point is the shape of the lesions. And this is extremely interesting if you take the time to concentrate in studying the shape of the lesions, because in my hands or in throughout the years of my career, I have noticed very specific and very unique shapes of the lesions for the different causes of multifocal choroiditis. So the 6 points of this clinical algorithm are over. Now we will take the VIPs, or the stars of the multifocal choroiditis, and then we will take one of them and apply the algorithm to it and show a few pictures to see if this algorithm really helped us at least break the ice between us and between diagnosing the cause of the multifocal choroiditis or white dot syndromes or not. We divide the stars, or the famous causes of white dot syndromes, into two categories, ones with vitreous infiltration and others without vitreous infiltration. The examples of the multifocal choroiditis or white dot syndromes commonly associated with vitreous cells include birdshot retinochoroidopathy, multifocal choroiditis with panuveitis, sympathetic ophthalmitis, VKH, tuberculosis, sarcoidosis, and malignancies. On the other hand, certain white dot syndromes or multifocal choroiditis entities are not associated with vitreous cells, no matter how active they are, because there is kind of misunderstanding that if the multifocal choroiditis or white dot syndromes are active, then they are associated with vitreous cells, and if they are inactive, then they are not associated with vitreous cells. Actually, the association with vitreous cells or not is a characteristic feature of the disease. For example, the PIC, the punctate inner choroidopathy, the PORT, the punctate outer retinal toxoplasmosis, the amphigenous and the serpiginous lesions, and the presumed ocular histoplasmosis syndromes are all free of vitreous cells, even when the disease is active. Now we will take one of them and apply the 6-point algorithm to it, and then take a few pictures to see if we have taken one step further towards diagnosing these confusing conditions. The birdshot retinochoroidopathy has a specific type of patient. This slide, the type of patient does not belong to the algorithm. It just describes the features of the patient most commonly falling a victim for the disease. The typical patient for the birdshot is a hypertensive patient. He is sometimes psoriatic, and he has got pate, that is to say, pinpoint-like hypomelanosis. Sometimes also he has sensorineural hearing loss. And for the last two causes, the guttate hypomelanosis and the sensory neural hearing loss, he is sometimes misdiagnosed as VKH. Because the common concept of the multifocal choroiditis with a hearing loss and some vitelliginous patches is always a VKH, unfortunately misleads some ophthalmologists into misdiagnosing a birdshot as a VKH. Now to our algorithm, we will explore together how the birdshot retinochoroidopathy complies with every point of the 6 points of the algorithm, and then we will take some photos to conclude. Regarding the site, the lesions of the birdshot are characteristically posterior, post-equatorial, and they are peripapillary. They are located or concentrated around the optic disc, and characteristically, very uniquely, they spare the macula. Regarding the quadrant, as I shared with you, this is a very important point in describing the lesions, the quadrant. Let's not forget it. The birdshot lesions are inferior and nasal. So, as regard the site, they are posterior, post-equatorial, peripapillary, sparing the macula, and located in the inferior and nasal quadrants. For the second point, the size of the lesions from day one. The lesions of the birdshot are large, and they enlarge with time, and they coalesce together and form larger patches. With respect to the borders, they are ill-defined. Whether or not the lesions are active, they remain ill-defined, even when healed. So when you look for healed lesions, do not look for definition of the borders. They will not be defined even when healed. The color is a very important point as well. The lesions of the birdshot are hypopigmented. They are not hyperpigmented. They do not accept the pigment. And as we have explained earlier, the range of hypopigmentation, some lesions could be chalky white, some lesions could be yellow, some lesions could be orange. These are very uniquely described as cream color. That is about 1/3 of the distance, if we can explain it that way, 1/3 of the distance between the white color and the yellow color. And it's very important to take into consideration that even inactive lesions do not tend to become hyperpigmented. So again, in the birdshot, do not wait for the lesions to become hyperpigmented in order to judge this patient as being healed. The fifth point, the elevation. The lesions of the birdshot are not elevated. They are patches. They are flush with the retinal surface. They do not form nodules, no matter how intense the activity is. And this is the sixth and the last and the most important part of this clinical algorithm, the shape of the lesions. The shape of the lesions of the different entities of the white dot syndromes is so specific and so unique and so seductive that you can't help but just looking at it. The lesions of the birdshot are oval, but still I can place an oval lesion in any orientation. No, the birdshot is very focused, is very professional. It puts its oval lesions in the sense that the long axis of the lesion is perpendicular to the disc, like the rays of the sun. And the lesions stand one behind the other, forming a queue, forming linear streaks that still converge towards the optic disc. This is very unique, and then we will see it in a moment. Now to the last part of the presentation, we will take 3 photos, 3 diagrams, and see if the algorithm applies or not. This photo shows the birdshot lesions. Number 1, the site of the lesions. Posterior, post-equatorial, as you see, we are showing the central fundus. Peripapillary, the lesions are concentrated around the disc. And the quadrant, please don't forget it. They fill the inferior and nasal quadrants. And then we come to the size of the lesions, very large lesions. The borders ill-defined. The color hypopigmented, cream colored, and no single lesion is pigmented. You have a look at the fundus, you cannot find any pigmentation in any lesion whatsoever. They are not elevated above the retinal surface, and this may be the only point that cannot be judged by a 2-dimensional photo. It needs stereopsis, 3-dimensional examination on the slit lamp. And then please concentrate with me on the last and the most important point, the shape. As you see, the lesions are oval, fusiform, like the muscle, if we can call them muscle shape, like the belly of the muscle. So the birdshot very carefully puts and arranges the lesions so that the long axis of the oval lesion is pointing towards the disc. And the different lesions, 2 or 3 or 4 lesions, arrange themselves one behind the other as if they are standing in a queue to form a streak that converge towards the disc. Another photo of birdshot retinochoroidopathy to screw home or drive home the message that we are trying to convey in this presentation. When you look at a picture like this, there is no need to get perplexed or confused or to carry out unnecessary investigations. We will take the 6 points in order. Number 1, the site of the lesions. Posterior lesions, post-equatorial, peripapillary, because the disc in this photo should be up here, and the quadrant. I cannot emphasize this enough. Inferior and nasal quadrants, very common to be affected in birdshot. Next is the size of the lesions, very large lesions, characteristically very large from day 1. The borders ill-defined. The color, cream colored, 1/3 between the white and yellow colors. And the point that I'll keep repeating, maybe till you memorize, is that no pigment whatsoever in any lesion in birdshot. The lesions are not elevated, but this we cannot judge from a 2-dimensional picture. And the 6th and the last and the most important point is the shape. The lesions are oblong, oval, fusiform, and the long axis is pointing towards the disc. And the successive lesions stand up in a queue, very organized, very professional, forming streaks that converge towards the disc like the rays of the sun. This is the last photo before I conclude. It's the same as the previous one, but maybe it shows that the disease spares the macula and spares the superior and the temporal quadrants. So you look at the fundus, you find hypopigmented lesions, cream colored, between the white and the yellow, never chalky white, never orange, no pigments whatsoever. Most of them fusiform or oblong, pointing towards the disc. The macula is free. The temporal and superior quadrants are free. And by this I conclude. And for the whole course that we teach for the postgraduate candidates in our university, please drop me a line or WhatsApp me. Thank you so much.
That was an excellent lecture. Dr.
Thank
Ayman,
you.
thank you so much.
Thank you.
We are really running short of time. So let us go quickly through a few of the questions. I hope Professor Kuan is online.
Yes.
First question is for you, Professor. This Acthar gel sounds very promising in scleritis. So the question is that, is it available commercially?
Yes, it is available commercially in the United States. Certainly, it may also be available worldwide as well. The difficulty with this particular pharmacology agent is that the cost of it is quite expensive, even at US standard. And that is not really appropriate, especially for many countries worldwide. So we are working with the manufacturer to determine what's the best way to bring the cost down. And at the same time, different other groups are also looking at the corticotropin ACTH pathway in an effort to make it more available, because I personally do not believe in medicine that costs so much, because it does not help people across the globe. But yes, it's definitely commercially available.
Okay, that's great. One more question is that in a patient of unilateral intermediate uveitis, if quantiferon TB gold and Monto is positive, should we treat as TB directly? So probably this question can be answered by Dr. Basu.
Thank you. I think, it's not about intermediate uveitis per se, but in general, the diagnosis of ocular tuberculosis is based on 3 pillars. The first is the presence of a clinical sign, which is suggestive of ocular tuberculosis. And here, intermediate uveitis is relatively low down the order, because it doesn't have a very specific clinical feature which is characteristic of tuberculosis. So that's pillar number 1. Number 2 is presence of any ancillary tests that suggest a tubercular infection in the patient. And you've already mentioned 2 such ancillary tests, the quantiferon and the Monto test. And the third one, which is probably the most relevant for the case you just mentioned, is the exclusion of every other infectious or non-infectious uveitis that might resemble ocular tuberculosis. And in this particular case, that would be most important, that you have been able to rule out everything else. Then yes, of course, we can call it ocular tuberculosis and treat it with anti-TB therapy.
Okay, that's great. The similar question is on this same, this one is in case of anterior uveitis, the clinically, if it appears as a viral, then and the AC tap shows a negative this thing, then should we repeat the tap, or what should, how to go about it?
Probably Dr. Shan could take this one, but yeah, again, viral anterior uveitis is, it's a clinical diagnosis. It's not based on the PCR results. Only in the atypical cases, you would want to do a PCR and confirm the diagnosis. If anyone else would like to comment on.
Yeah, but
I would also add that. Oh, go ahead, Dr. Shan.
Oh, sorry. Yeah, I think if the index of suspicion is high, I would repeat the tap. But of course, if it has come back negative several times, then I mean, just based on the clinical features like a falling endothelial cell count or raised intraocular pressure or specific iris changes, then we'll discuss the option of sort of empirical treatment with the patient and see if they respond to that.
I also like to point out that a lot of the chronic anterior uveitis, especially when it's recurrent, based on the work of some of our great colleagues, such as Dr. Soon-Pek Chee from Singapore, please be sure that you actually should indeed do a piece of that, because, for example, it can grow out agent like cytomegalovirus, which is one of the major work that Soon-Pek published in this aspect from there. And then at that time, in addition to the anti-inflammatory, we can also add an antiviral. That entity that we know, that type of CMV anterior uveitis, is completely different than the CMV retinitis that we see posteriorly. But when we have that thing, then we can combine antiviral and anti-inflammatory to decrease or eliminate recurrences.
Okay.
What do you think about the role of the topical steroid in viral anterior uveitis? I mean, would you start the patient?
So actually, if my index of suspicion for viral anterior uveitis is high, I would tap the patient and I would start Nevenec and antibiotic eye drops. And when it comes back as positive, then I'll start the antivirals. I don't find that the steroids actually with the antivirals on board, I don't really need the steroids usually.
Thank you.
Okay. Those are all questions. Yeah.
No further questions?
No, that's it.
All right, then I will just close the session now. Thank you very much to all the speakers for sharing your knowledge and experience with us. And thank you very much to all the attendees for your time. Thank you.
Thank you.
Thank you
So much.
I want to take a